Welcome to Behavioral Health Today, a podcast brought to you by the Triad Network. This podcast is designed to share trending topics occurring within the world and our communities and bring them a behavioral and mental health perspective.
Welcome to Behavioral Health Today, a Triad production. I'm your host, Dr. Graham Taylor. My guest today is Tracy Gilmour-Nimoy. Tracy brings both lived and clinical experience to today's show, including difficulty conceiving, infertility, high-risk pregnancy, traumatic delivery, infant pregnancy loss, and pregnancy after loss. Tracy is a licensed marriage and family therapist and certified perinatal mental health professional. She works with individuals, parents, and families throughout their reproductive and family starting journeys, and has become a fierce advocate of perinatal and reproductive mental health, with the goal of supporting and empowering other women, individuals, parents, and families. Tracy is a return guest to our podcast. In our first show together, we named and discussed the three what we called transitions experienced in one's life within the context of Tracy's clinical focus. They included pregnancy, infertility, and postpartum. She shared with us some of the common experiences she hears from folks going through each of these transitions. It was a great show, and if you haven't listened to it, I'd recommend you go back and do so. We're so very excited to have Tracy with us back on our show today as part of our Clinicians series, where we're going to take a deeper dive into the techniques and strategies and constructs around perinatal mental health and the unique ways that Tracy works with those that come through her door. Tracy, welcome back to our show.
Thanks so much. I'm so excited to come back and be here. Appreciate it.
Great to have you here. You know, as we set this up with this focus today, the perinatal and reproductive mental health, if you would, what is typically going on in the life of those that are walking in your office and coming to see you?
Yeah, it's a good question. Reproductive and perinatal mental health is a pretty broad spectrum specialty. And so what most people think of when they hear that is pregnancy and postpartum. And that is a great portion of it. I'm a little different in that I focus more on the subspecialties. So I do that. I do pregnancy and postpartum, but I really have a special place in my heart for pregnancy loss, infertility, birth trauma, donor conception, surrogacy, adoption. And so I'm really looking at the experiences that maybe not everybody is going to have. They're kind of entering it thinking, I'm going to be pregnant, I'm going to be postpartum. It's like they're expecting certain experiences to happen, and then it doesn't go as planned. And so while I do it all, I really focus on those sort of subspecialties.
I want to just highlight that because what you did so vulnerably, and we were so appreciative of it, was to share your journey in our first podcast. And without having to go over it today, I'm going to encourage our listeners to go back and take a listen to that because it was so powerful. And I think the vulnerability and the candidness you had, really the transparency in that podcast, I think invites people to recognize that it is safe to talk about this. It's important to talk about this. And there's a place and a way to do it that can be really therapeutic. So when folks are coming in and you have this focus, and especially typically, what are they walking in with? And how are you beginning to kind of assess, hey, what might we take a look at here and use therapy for in a beneficial way?
Yeah, well, I think a lot of this stuff presents as anxiety. And like even prior to something going wrong in a pregnancy, the feeling is anxiety. And oftentimes people will get labeled as being, quote, just anxious, like just an anxious pregnant person. And it's really common that a person will have a bad feeling about pregnancy and will go to the doctor, and the doctor will say, oh, this is just anxiety. And so that's a primary emotion. And now if we're talking pregnancy loss, then we're talking trauma. And how does trauma present? Well, it often presents as anxiety. I'm scared that this is going to happen again. I don't feel safe. It rocks the sense of safety. And so anxiety, trauma, depression, of course, if someone's losing a pregnancy, if someone can't get pregnant, if someone is in the midst of a pregnancy after loss or a high-risk pregnancy, they're going to be feeling sad. They're going to be feeling depressed. And so I would say anxiety, depression, trauma are kind of the way that these things present at the onset.
I know what you're describing right now is you're kind of normalizing and kind of universal, this idea in therapy, we get to kind of universalize, if you will, that you're not the only one. And we begin to kind of normalize that these are normal experiences given what you've gone through or currently in. Oftentimes I think about anxiety as the perception of a threat, whatever that may be, and the perception that I don't have control over that, or I'm not going to. And the key word in there is the lack of control. Exactly right. So the idea is that the key word in that is the perception. And I would imagine that
Right.
a lot of this is, I don't feel like I've got the ability to cope or manage with this. How do you start to
Yeah.
name for them and normalize depression,
Yeah.
anxiety is common within the context of this trauma? And here's how we're
Yeah.
going to lean into this.
Yeah. Well, it's such a good question because here's the thing is pregnancy, even when everything goes perfectly, is
Yeah,
anxiety provoking.
you bet.
It's an experience that happens in your own body. And what's unique about it is that there are two patients. There's the baby
Mhm.
and there's the parent who's carrying that pregnancy. And so not only are you focused on the carrier's health throughout the
Yeah.
pregnancy, but then, keeping this baby healthy and alive and safe. So most people are going to feel a normal dose of anxiety in pregnancy without any challenges. Now, if you throw in, okay, like your scan came back and there's something concerning, or your blood pressure is really high, or you have gestational diabetes, or
Mhm.
there's a history of a high risk pregnancy or a really tough delivery, a traumatic delivery, it's not only anxiety, it's trauma. And what's different about trauma, even though it presents kind of similarly to anxiety, is that it's rooted in lived experience. Whereas like
Mhm.
anxiety might not be, it could be a catastrophic fear, right? It could be like, I'm scared that I'm going to walk into this building and all the elevators are going to break. And it's like, well, has it
Right.
ever happened to you before? No, it's never happened to me
Right.
before. That's an example of of anxiety. That's anxiety. I'm
Sure.
scared this is going to happen. And so you really have to be able to know the difference because I can't treat trauma and the anxiety that accompanies trauma in the same way that I would treat anxiety like that.
Mhm.
I can't say, this is really unlikely that this could happen. Could it happen? Yeah, but it's highly unlikely because when someone is coming to me and they've lost a pregnancy, I can't say to them, you're never going to lose another pregnancy. That doesn't
Right.
happen. So it's very different the way that I look at it when someone comes in.
And that sounds like an important starting point of, this is not just something in your head. This is not something that like
Yeah.
what if or could be, or
Yeah.
this is something
Yeah.
that's, I like what you said, rooted in
Yeah.
experience. And this is real. And the
Yeah.
perception is not just this has happened and what's going to happen possibly this time. Tell me, sound like you're talking more about women right now, holding at
Yeah.
this for a second. If
Sure.
there's a partner in the room with them, what are they
Yeah.
experiencing? What's the difference between the genders and their response to these things that are coming up? Anxiety, depression.
Yeah. So what I typically see, and of course everybody's different, what I typically see is that the non-pregnant partner feels like they have to be strong and keep it together. And
Mhm.
the person who's pregnant or trying to become pregnant, like the focus is on them, which, makes sense, they're the patient. But in some ways, it creates this relational divide where
Mhm.
then the person who's pregnant feels like, oh my gosh, my partner doesn't get it. They're just telling me to think positively and to stop being anxious. And then the other person feels like they have to be strong. And so they might be actually feeling that way, but they're not vocalizing it. And so, like,
Yeah.
and nobody checks in with them, at least
No.
not as much. Like, I remember just like in my own experience, and I'll give a quick clip note version of I
Please.
had a third trimester loss. And I was a therapist prior to that loss. And I went through the process and realized that nobody knew what to do or say to me. And very traumatic delivery that I almost didn't survive. And then following that, due to the surgeries that saved my life in that delivery, have had multiple miscarriages and infertility. So, in my own experience, like nobody checked in with my husband. When they
Mhm.
called him to check in, it was, how's Tracy? And I remember he just kept saying, I'm fine, I'm fine. Like, I don't feel anything. And then complete meltdown, a year later
Yeah.
of, oh, wow, this is really impacting him. And so I think because we aren't used to acknowledging the experience of the partner, it can go missed
Mhm.
and it can create relational distress.
Mhm.
And they need a lot of support to realize that one, everybody has a different experience and it's okay if they don't align. But oftentimes, what I see is that it's usually the person who's pregnant that will grieve more openly and be
Mhm.
more dysregulated or expressive in those emotions. And the partner will be more stoic. And then with time, that person who's pregnant will learn how to regulate and they won't be crying as much with time. And then the partner will sort of fall apart. It's like the
Mhm.
over functioning, under functioning. When one person's functioning up here for the system,
Yeah.
the other one can kind of fall apart and then it kind of switches as that person,
Kind of
is
like the
able to
late
function more.
response. It's such an
Yeah.
interesting piece because it's, let's just say the non-pregnant partner, the guy in this situation, let's say, might
Yeah.
might be
Yeah. Or
wanting to be
women if it's,
supportive. Yeah,
same
sure.
sex
Depends.
couple.
Yeah.
Yeah.
So let's say that
Yeah.
let's say the non-pregnant partner, you know, in in those cases, they want to be strong and they want to hold the person up. And it
Yeah.
almost feels selfish that how can I express, what I might be going through if they're the ones that are, that are pregnant and I'm just
Yeah.
trying to be here. And I could see where
Yeah.
they're not gotten, they're not talked in or talked to
Yeah.
or checked in. But what a nice space I would imagine that
Yeah.
you're able to create for them,
Yeah.
the not pregnant partner in the therapy to say, hey,
Yeah.
let's not forget you.
Yeah, and I remember so clearly, like, in my own experience, and then I see this in therapy all the time where, like, they get frustrated. They're like, "I want you to be upset about this. Like, this is upsetting.
Right.
Stop pretending." And I remember my
Right.
husband used to just say to me, "I need to be strong for you." And at one point, I remember just like screaming at him, like, "I don't need you to be strong. Like, I need you to be real. Like, what is
Yeah.
happening? Like, are you not depressed about this?"
Yeah.
And I remember that was just like kind of the moment where he could just kind of like fall apart. And then he would share with me how depressing it was for him and how
Mhm.
painful. And I think what's important to mention is that there are differences in these processes. So the person whose body it is going to have the medical trauma and the
Mhm.
physical intervention and pain and recovery. The person who's the partner is going to have the added emotional trauma of witnessing their partner go through it.
That's tough.
So yeah, I mean,
Well,
it's
you talked about this idea of trauma. It's a lived experience, even
yeah,
in vivo in those moments. Trauma
yeah,
experience outside the realm of normal experience. That's
yeah.
huge, and to watch that take place and to vicariously be a part of that, that is traumatic, isn't it?
It's so traumatic, yeah, and to feel helpless, like,
Hmm.
you can't do anything to help that person,
Hmm.
to make it better for them, or to even, like I hear a lot of partners say, like, "I wish it was my body. I wish I could go
Hmm.
through the procedure or surgery,"
For
because,
you.
like yeah, I mean, because that's the thing is it's not just like, this is what's so unique about any trauma in the, like, reproductive space is that it's medical. There's a medical procedure, usually multiple medical procedures. So it's not just like, okay, you had this traumatic incident and it's one incident, it's
Hmm.
multiple follow up. And then usually it's continued follow up if you're trying to get pregnant again. So it's like you actively put yourself back in a situation that will likely reactivate and trigger the trauma.
You
Whereas
bet.
with some other traumatic experiences, you can kind of avoid. You can say, like, okay, I had a really bad experience at this summer camp. I'm never going back to that summer camp.
Hmm.
But if the goal is to try to get pregnant again and you've experienced trauma, you have to kind of put yourself back into
You've
that.
got to go through that again.
Yeah. I mean,
Yeah.
even like something as simple as like going to the dentist can be really
Mhm.
traumatic because you have the bright the light. And if there's, lights in a medical setting, you're often laying down and you're laying down when you're having these examinations. And so even something like that can be really dysregulating for someone who has fertility
Absolutely. I
trauma.
think that's a good reminder that, you go through it one time and you're going to go through it, go through it again. You got to go through the same experiences and the same things being
Yeah.
triggered and brought
Yeah.
back up. And trauma gets locked in our neural network, doesn't it? Those things
Yeah.
get stuck there and the body remembers as
Yeah. The
well as the
body
mind.
keeps the score.
Body
Yeah.
keeps the score. Absolutely.
And it's important to recognize that these aren't just, easy appointments. These are
Mhm.
appointments where you're naked and
Yes,
someone is doing a very vulnerable examination.
you
And so
bet.
you're very physically vulnerable in
You
addition to
bet.
very emotionally vulnerable. And this brings up like the challenge of lack of trauma informed care in medical systems of like you're going in not only having to deal with that, but often someone not acknowledging the loss or saying things that are really hurtful or dismissive. And so it's really, really tough to go back into these situations.
That would be an interesting show at some point to come back and talk to kind of our medical colleagues about trauma informed care. I used to do a number of talks when I was working at a hospital
Yeah.
with physicians about ways to relationally connect first and then to
Yeah.
build whatever medically things they had to address. But that's such an
Right.
important cornerstone. And when that cornerstone's not there, oftentimes the
Yeah.
physicians wanting to be positive or maybe not kind of wanting
Yeah.
to go down that path
Yeah.
emotionally because they don't know what to do with it if it opens up, they stay
Yeah.
kind of sterile and hygienic and it misses a great opportunity. I've
I
to
would
talk
love
about
to come
how,
back if you did like
yeah,
a panel with doctors because this is
yeah,
a big part of my work. I don't just do therapy. I'm
mhm,
talking to your doctor. I'm doing
yeah,
case management. Most people are coming in and they say, I need a new OBGYN. This one wasn't supportive or they said this or they didn't say this. And so when I get the doctor on the phone, I'm like, use me as a tool
that's
because
so good.
I feel for them. Like they're not therapists. And I do
No,
think while it would be great if they had a little bit of like the training, it's really an unfair expectation to place on them. They
Mhm.
also don't get an hour with each person like we do. They
Mhm.
get 15 minutes. A good doctor who can kind of bend the rules a little bit, who's trauma informed, will give more time in situations like these. But they don't have the training that we have. I mean, I have a lot of friends that are doctors, and we talk about this all the time. And I ask them, what mental health training did you get in school?
Mhm.
And the answer is always nothing.
Right.
A round of psychiatry in the
Right.
hospital. Like,
Exactly.
they don't get it. They don't know how to interact with patients. And it's really simple things. Like, if I can tell a doctor, ask the baby's name, or just go in and say, this is so awful. If I can give them just like
Just a
a
few
simple
little,
few word
that's right.
phrase,
All right.
here's what would be helpful. Don't put them in an exam room full of baby photos.
Right.
Read the chart before you walk in, so someone doesn't go in and say congratulations, or so they're not asked 10 times, why are you here, when they're there for, to check again because they know there wasn't a heartbeat. Like, very simple things, like the things that are free that cost nothing but mean everything.
Yeah.
Then like that patient's going to go in and have a way better experience, and that doctor is going to use that when they meet with other patients.
It's really good. We'll be right back after word from our sponsor.
Most of us spend more time at work than anywhere else doing anything else. So why not spend that time in a job you love? Introducing Triad's Jobs Marketplace, the only job site dedicated specifically to behavioral and mental health professionals. Featuring more than 1,000 open jobs from dozens of behavioral and mental health employers, and searchable by location, professional field, employment type, specialization, and more. Jobs Marketplace helps you find your next career opportunity. Full-time, part-time, or gig time, make the most of your time. To access Jobs Marketplace, register for your free professional account at hellotriad.com/BHT. That's hellotriad.com/BHT, and then click to Jobs Marketplace. If you're already a member of the Triad community, visit app.hellotriad.com/jobs. That's app.hellotriad.com/jobs. Visit us today and take your next career step tomorrow.
Really good. I think that's where we get to kind of equip some of our medical colleagues, and they have great hearts and they have great intentions and they're bright and they're doing right things. But adding that relational component can make all the difference in the world, particularly around this area where there's trauma just surrounding it. And so I love the idea too. I want our listeners to kind of pick that up, that one of the things you do is you are in contact with your patients, physicians, and kind of doing kind of a team care approach, which I really love. Let's talk about, some of the places where couples might get stuck or they're particularly just really struggling. How do you enter and how do you help work them through exercises, approaches, techniques? What are you doing when someone is really struggling? And maybe kind of pick an example and walk us through it.
Yeah. I mean, I think like the biggest thing with a couple is the communication. Like, I see that for every couple, and it's true in trauma and grief, of like going in and acknowledging that each person is going to have a different experience and that that's okay. The key thing is that we can't expect our partner to have the same experience as us, but we also can't expect that we then don't meet their individual needs. And so being able to help them advocate for and recognize, like, what do I need from you? And what do you need from me? Knowing that that might be different.
So just as a start, if I could just jump in on that, but I just kind of want to frame something first. You're going into two steps. The first step is I want to kind of psychoeducate them in the idea that we're going to have different experiences, same moment, different experiences in it. Same journey, but it's a different journey that we're each going to have uniquely. And that's a normal and okay thing. And then you're taking it a wee bit deeper and you're saying, let's start talking about your journey and how they're uniquely going on. Take me into that part.
Yeah, you're right. So that is the processing of the experience, right? Like, what's coming up for you? Where do you feel it in your body? What are the emotions? What's going on for you in your head? What are the thoughts? Oftentimes it's things like, my body failed. For the person who's carrying, if we're talking pregnancy loss or infertility, for the person whose body is, my body failed, or I failed you, I can't give you a child. For the other person, it's often things like, I don't even want to talk about this. I don't want to upset you. That's a really common one. If I bring this up, you're going to be upset. And the other person's like, I want to talk about it. I want to know that I'm not alone in feeling this.
Right.
Because what happens with that discrepancy that we talked about is then one party feels like, okay, I'm messed up and this person's fine. And
Yeah.
now the expectation is that I get on their same playing lane or their field, right? And I need
Yeah.
to be fine. And that creates a really big problem because now neither person needs are met. So that's the
Mhm.
processing. Kind of like
I'm imagining as we're having this talk today, for those that get to watch this, you'll see Tracy's office here. Those that are listening, let me just kind of create a vision for you. This is a very inviting office you're sitting in right now. And I'm imagining as you got that couple on that couch behind you, you sometimes in helping them individually begin to kind of discover within themselves, maybe even explore within themselves, the very things you're describing right here. What am I feeling? Where did I carry it in my body? What's going on?
yeah,
What are my thoughts, feelings, needs, hopes, fears,
yeah,
all those things? It's
yeah.
very hard for couples to turn and face each other in the
Mhm.
beginning of therapy sometimes, just say, hey,
Oh
let me
yeah,
tell you what's going on. And I can imagine you kind of getting your chair and kind of going knee to knee and
would
just kind of going face to face with one of them and kind of
yeah,
holding that while their partner
yeah,
listens and kind of goes, oh, I didn't even know that. And then kind of
yeah,
stopping and holding that piece and then going to the other couple and saying, hey, what's that like to hear?
yeah.
What
What
comes
comes
up
up
for
for
you as
you
you
when
hear?
you hear
Yeah,
that?
tell me about that. Yeah,
Yeah, yeah,
exactly.
yeah. I mean, yeah, exactly. I mean, using my body as a tool, right? Like my body language, like my leaning in, my affect, mirroring, like mirrored, what I would call mirrored attunement, reflecting back like what they're saying. So if I see pain on the face, I'm mirroring pain,
Yeah.
right?
You can't
And
help but not feel that too.
yeah, I mean,
Yeah,
it's
absolutely. You're holding that with
inevitable.
them.
Yeah.
Absolutely.
100%. I mean, it's a sacred space. Like when you're in it, you're in it. I mean, I cry with people when they cry. I mean, it's really such like a tender specialty because
Hmm.
I mean, it's babies and it's people's lives. And it's like what people imagine. And then it goes the complete opposite direction. It's
Hmm.
relationship at every level. And it's like they often talk through the therapist. And so it's saying like,
Yes.
I pause people and say, I'm going to ask you to do something that's going to feel uncomfortable. I want you to repeat everything that you just said, but I don't want you to look at me. I want you to look at your partner.
Very good.
And if it feels right, hold their hand
Yeah.
or put your arm on their back. And sometimes like when someone's sharing something really vulnerable, I'll stop and say, what do you need from your partner? I'm gonna say, I want them to rub my back or
So
I
good.
want them, things like that. And so really
Yes.
keying into the body language and having them not talk through me and then
Mhm.
slowing them down because sometimes people will go very quickly and I have to pause and be like, hold on 1 second. This is really big. Let's sit with this for a minute. And then going into
Yeah, so good.
what is it like to hear? And then a lot of times people are like, I had no idea.
Mhm.
And they can kind of come in and like correct that narrative.
Mhm. Mhm.
If someone's saying, I failed you, the partner can come in and say, you're not a failure. I don't blame you. And so like it's like, oh, like that's the work.
Guys, got folks that are listening and just as you and I are talking, Tracy, that is the work right there. That is
Yeah.
just a lovely description of what gets to happen in that sacred space
Yeah.
that invites people to come in. You were saying earlier that when we begin to share ourselves, there's a desire to be known. A colleague and I
Yeah.
do a lot of couples work, refer to it as knownness. That's one of our
Mhm.
greatest needs, to be known. And that knownness comes from,
Yeah.
at its best, vulnerability, the ability
Mhm.
to transparently and candidly and honestly, vulnerably share ourselves. But it is such a scary thing. I don't know how you're going to respond. I don't know if what I share with you is
Yeah.
going to burden you. I don't know if I'm allowed to say that.
Yeah.
All those things
Yeah.
come into play. But what I love that you're doing is you're so present
Yeah.
with those that are sitting on your couch right behind you there and inviting them into that
Yeah.
vulnerable space so that knownness grows.
Yeah.
And what comes from that is that shared understanding. And out of understanding comes empathy. And out of that
Yeah.
empathy comes this connectedness and a depth of growth that people so long for, but oftentimes really don't know that they long for it as deeply as they do. And then when they begin to experience it with you, I
Yeah.
would imagine you see
Yeah.
some beautiful things emerge on
Yeah.
that couch right there behind you.
Yeah. And I think what you're describing is really the therapeutic relationship. Like, what is our
Mhm.
job as a therapist? It is to see people, to know them, to allow, to create a space where they can be who they are. And it doesn't matter if it's not what we're supposed to do or say. And I always tell people because I feel like we have weird jobs and people come in and they want to like win therapy or like they want to get an A plus. And I tend to attract like high achievers. Like this is the population. It's the people that are like at the top of their careers, they're doing well. And then for the first time,
Yes.
it doesn't go well with fertility. And that is like just like such a mind fuck for them. They're like, but I did everything. I did everything I was supposed to do,
Right.
you
And it's
know?
supposed to
And
go a certain way now.
yeah, and it's supposed to go a certain way, and so they
Right.
come into therapy of like, "Tell me how long I'm gonna grieve for, tell me what I need to do," like, "Well, I want you to like me." It's this whole thing, and,
Mhm.
I wait for the rapport to build a little bit, and then I like to tell people, I like to say, like, "Listen, like, I love and care about you, and there's nothing that you could say to me that I, A, haven't heard before, probably have experienced myself, or would make me think any differently about you, and if you're not sharing honestly about what's going on, about those dark thoughts, or about the things that you feel like you can't say, I can't help you. I can only help what I know." And that is always like the moment for people where they're like, oh my, like, okay. And then we can kind of like break through that barrier. And it's that authenticity that leads to what you're
Mhm.
talking about of feeling known and feeling understood. And it's really fascinating because if you ask people, what is the most important human emotional need? Like, what do people usually say? Love. I want to feel love. And
Yes.
that's not the most important need, according to research, is what you're talking about. It's to feel known, to feel understood, which leads us to feel love.
Absolutely. And if you love me and you can hold that space with and for me, I'm going to
Yeah.
feel so loved beyond words.
Yeah.
And there's something so intimate about that and so connecting
Mm.
around the effort being made to understand each other and know. And that knownness, you're right.
Yeah.
That's the precursor to the love that we seek so deeply with each other.
Folks, pardon the interruption, but we'll continue this discussion on our next show. This is your producer, Peter Fenger. On behalf of Dr. Graham Taylor and our podcast, we want to thank our guest, Tracy Gilmour-Nimoy, for coming onto our show today. For more information about perinatal mental health and Tracy's private practice, please visit tgntherapy.com. If you're looking for more resources on perinatal mental health, please visit tgntherapy.com/perinatal-resources. And lastly, I want to thank our listeners for tuning in today, and we look forward to seeing you next time on Behavioral Health Today. We appreciate all the support from our community, and if you like our show, one of the best ways you can support it is by giving us a 5-star rating and leaving a review. Behavioral Health Today is a podcast part of the Tribe Network, all rights reserved.